Thank you very much, Maria. And you're quite right. I did warn the ESIS team what I was about to tell you and get permission for it before I went ahead. So thanks very much for listening today. The first thing I'm going to start by saying is it isn't perfect in Cornwall. Anybody who looks at our performance against the 4-hour standard and at our delays and our handover delays will know that we've still got significant challenges. And one of the things that I think is important to recognise is when you work in a system, particularly one that's as remote as Cornwall, it is quite easy to lose touch with the way things are done in other parts of the country. And so quite a lot of what we do we consider to be normal for Cornwall. And so it was helpful when the ESIS team pointed out some of the things that are different in Cornwall. So I'm going to try and focus on the things that I'm told are a bit different in Cornwall. And as I say, some of the benefits of those and some of the challenges. Next, please. So we've got a really clear set of priorities around what our escalation plan is supposed to be achieving. And we're increasingly over years moving towards early indications of pressure rather than once we hit the red button because ambulances are queuing at the door, then everybody rushes to help, but trying to get to the point where we can see pressure building in our district nursing teams, where we can see pressure building in primary care, or where our reablement services are maybe getting their waiting times are increasing, and we're improving that year on year. We're not there yet, but we want to make sure that we're clear around not only our escalation arrangements, but the pre-agreed actions that we put in place to make sure that they've been impact assessed, and then try and get that thematic learning, because one of the things that I'm sure you'll all recognise is you take actions in escalation, don't always take the time to go back round the loop and check which bits worked well and which bits didn't. The other thing that we're moving to now is trying to get ownership out into our local areas. So we've got 3 integrated care areas around Cornwall, which is particularly important in rural areas because the characteristics and the pressures they have to deal with can be really different in the 3 areas. Next, please. So we've got a set of principles which I won't talk through in detail, but some of those are around resolving pressures in local communities, and that's something that's developed during COVID, particularly because our strategy around COVID management was to increase our capacity in community settings, not just in acute settings, which was the national direction. And so that goal basically drives everything we do in the development of our escalation framework, and we're tackling some of the challenges about some of the community-based data not being as readily available as the acute data is. There's also something behavioural around getting people to understand that escalation isn't a bad thing, but we did agree as one of our principles that we weren't going to talk about escalation, and so we haven't quite got the other word yet, but we're talking about predicting pressure, preempting, intervening, calling for help, those sorts of questions, because escalation has got negative connotations and makes people feel like they have failed to deal with something themselves and they now have to escalate. There is a real commitment to parity and understanding across the whole system and understanding different people's cultures, and I'll talk a little bit about how my role plays into that. And also we've recognised that whenever we try and do something or take a different action in escalation, the lag between doing something and it having an impact can be as much as 48 hours. So again, we're trying to get 48 hours ahead. Next, please. We've got a dashboard that we've set up, which we're in the process of refining it. And again, one of the principles is this is available to everybody across our service. It starts in terms of our pathway with our 111 out of hours service. We look at ED in this dashboard, our minor injury units, SWOST, we look at admissions, inpatient flow, discharges out. And as I say, we will be further developing it. We've set operational standards, so what does good look like, and our escalation framework is based on deviation from those standards. We deliberately haven't set standards that are achievable, we've set standards that are the right things to do. And so, for example, we had a real debate when we were setting the standards for ambulance handover delays about how unrealistic it was to set 0 as our standard. But again, in terms of culture, we said, actually, so what's the alternative? We say it's okay okay for 10 people to be held in the back of an ambulance while we're coming in, and we're not going to react at that point. So we have set some really challenging standards, and we expect to be in Opal 2 or Opal 3 quite a lot of the time, because we didn't want to dumb down the level of expectation we have for the people in Cornwall. Next, please. So, as I say, I have sought advice from our ESIST colleagues about what are some of the things that are a bit different in Cornwall, so I can focus on those things. I think it's fair to say that the whole system owns the 4-hour standard and flow. It isn't an acute problem, to the point where I challenge when people say, oh, we've done X to help the hospital out. And I'll go back and say, no, you haven't done it to help the hospital out. You've done it to make sure that people in Cornwall can get access to the care they need. And that feels really pedantic sometimes, but it's really important in terms of setting the culture, particularly out in community services when people are really busy and they say, well, why should we stop doing what we're doing to help the hospital? Because one of your patients or one of your friends or one of your family members might be in the next ambulance that turns up and can't get admitted. We've got a focus on the pre and post acute, not just the acute, and that's quite hard because all of the national direction and all of the national changes are all focused on what's going on in the acute. We have calls every day, and again, I had forgotten that this is not in place everywhere. So whether we're in escalation or we're not, we have an 11:30 call every morning. 364 days of the year, actually. We give them a day off at Christmas, and the operational teams get together, discuss what are the issues to be dealt with that day, open and transparent sharing of risks, even if people are managing them or if they're outstanding, discussions about mutual aid and down to patient level discussions if necessary about particular delays, for example. One of the different characteristics, having worked in 2 or 3 different systems, is we have quite early senior involvement, and that has got benefits and risks, which I'll come on to in a little while. So our chief officers get involved in our escalation, and I know that that doesn't happen in a lot of systems. And again, that culture of it's a good thing to raise the red flag and to identify risks and to bring people in early and to resolve them before things get worse. And again, I get people giving us feedback about it's quite difficult in your system, Karen, isn't it? And it's a lot easier in other systems. But again, that objective challenge to make sure that we resolve issues and don't leave them alone until they're resolved. And just an illustration there of the types of people who are involved at each levels. Next, please. One of the things that's really important is that really passionate and compelling narrative. So our objective in escalation is maintaining safety standards and people's experience of care. That's 24/7, and it's even in winter, and there's no excuse for saying, well, it's busy or it's winter or it's summer or whatever it is, or it's overnight and it's always like this overnight. Setting that real high expectation and all of the dialogue being around, what are we going to do about patients in the back of ambulances? What are we going to do about the fact that there are long waits for home care? And it breeds a different type of behaviour. It works well in Cornwall. We do use data routinely, not as well as we could. And we've got some really good examples of mutual aid. So if a care home, for example, is at risk of admitting people because they've got staffing problems, we'll send staff from the acute hospital or community hospital out to the care home. We've got doctors from our 111 and out of hours service will go and provide mutual aid to our community services provider if they think they might have to close a minor injury unit because of lack of doctor cover. And that's built up over the last 12 to 24 months. I've also observed that our response times are different, and we set probably what people might consider to be quite unreasonable expectations. So when people are asked to do something, it's usually measured in hours and not days. And the other thing is we will rapidly try the unthinkable and fail and try again. And there's a lot of courage around in our system in terms of just trying something that it might not work, but we'll try it again. And as I said, we do have a system director post, which is the post I'm in at the moment, which is organisationally agnostic and aimed at holding these things together with that senior involvement and I think really importantly, building those relationships between the very top of the organisations and the very bottom of the organisations. That's when I get all my best insight, when I have a social worker or a district nurse who will pick up the phone to me and say, just wanted to let you know this, Karen. And then I get the chance to work out how I deal with that and how I use that information for positive gain without breaching their trust, because sometimes they'll be taking risks and telling me that sort of thing. Next, please. So the leadership, we have our chief executive officers from acute, community and mental health services, our integrated urgent care service. We've got a joint CCG and social care accountable officer, and the chief exec from our biggest voluntary and community services, and they are our gold. And we have medical directors and the GP lead from the CCG involved, and they are really intolerant of below standard care. They carry that patient-centred narrative. They model the expected behaviours that are focused on system and population and staff. They're really unreasonable, and sometimes that gets really unexpected results. But they do allocate resources, and they unblock things, and they make things happen, and they take risks where necessary. Next. And my role is around being organisationally agnostic, accessible and visible, getting out there, finding out what the problems are, resolving problems, listening to people who work on the front line, and trying to increase the connection with primary care. And the last slide, I think, these are the challenges. So it can be exhausting. Our relationships are often tested. We often set planned work aside for solutions today, and some of the solutions that we force ourselves to do on that day might not really be the right thing to do, like putting people who don't need bedded care into bedded care. And our performance is still not where it needs to be, and delays still remain high. But we're always in it together, and that does feel quite different.